Welcome, everybody. I'm Jeff Borenstein, and I have the privilege of serving as the president and CEO of the Brain and Behavior Research Foundation. And I'm thrilled this evening to serve as a host in a conversation that we've entitled Helping Children and Adolescents with Emotional Problems. I'm speaking this evening with one of the top experts in the field, and I am so thrilled to have Dr. Daniel Pine as our guest for this conversation. Dr. Pine is the Chief of Child and Adolescent Research in the Mood and Anxiety Disorder Program at the National Institute of Mental Health. He's also a longstanding member of the Brain and Behavior Research Foundation Scientific Council and a winner of the very prestigious BBRF Ruane Prize in 2011. That prize is given for outstanding achievement in child and adolescent research. Today, we're going to focus our conversation really geared for teachers, school counselors, other education professionals, as well as parents and other family members, with the goal of providing information that people could use. So with that, I want to jump right in, and I want to start, Danny, with the issue of anxiety in children and adolescents. Tell us about anxiety, the scope of the problem, what it looks like in a child.
So there's a few important takeaway points to make when we think about anxiety in children and adolescents. The first is that anxiety is a common part of life. We all have anxiety, and children in particular, as they develop, as part of their normal behavior, have anxiety, and that can present in many different kinds of ways. As mental health professionals, where we really have a concern is when a child has an anxiety disorder. Anxiety disorders are probably the most common mental health problem we see in all of childhood. At least 10% of children will be affected at any one point in time. And one of the tricky things for parents and teachers and even children is to tell this difference between when is anxiety normal or an expectable part of growing up and when is anxiety part of a disorder. And the simplest rule that we can use is that when anxiety prevents us from doing things that other people can do, or when anxiety prevents our children from doing other things that other children can do, that's when we think it's an anxiety disorder. So if a child can't give a presentation in school because they're too nervous to speak, that's a suggestion of an anxiety disorder. If a child can't go on overnight visits to friends or can't spend time in their room alone, that's a sign of an anxiety disorder. Or if a child is so worried that they won't be able to do things like go to a sporting event where they're afraid that they're not going to perform well, those are all signs of anxiety disorders.
So if it's affecting their functioning, then that's sort of when you sort of cross the line into a disorder, as opposed to the normal amount of anxiety that we all may feel that's healthy and fine to feel.
That's exactly right. And the usual way we see that effect on functioning is through avoidance, meaning that children don't want to do things that make them afraid.
And often as a parent or an educator, we may want to sort of help that child. I'm putting help in quotes because it may not be helpful, by assisting them in avoiding that activity that may bring on the anxiety. What should we do?
Yeah, that is an excellent question and an excellent thing to think about, because we do a lot of research on children who are showing, say, mild or not quite clinical signs of anxiety, and we follow those children over time as they grow up. And there are a lot of things that predict what's going to lead to persistent anxiety. And one of the things is exactly the kind of behavior that you describe. The children who we see who have some minor problems with anxiety, where the parents encourage them to face their fears, and have the children go and attend the kind of events that make them afraid. When we follow those children over many years, we find that those children actually do better. They have lower rates of anxiety compared to the children who are not pushed to do the kinds of things that make them afraid. Now, it's a difficult call for many parents about how much to push their child. And if you're a parent or if you're an educator and you're not really sure about that, that's where mental health professionals can be particularly helpful. And usually the good place to start is with your pediatrician. Pediatricians are actually quite familiar with the full range of behaviors, and they're also quite able to help you as a parent or as a teacher to find access to mental health professionals who can work with parents so that they can push their kids in an appropriate amount.
So if it's really affecting the child's functioning, really want to talk to the pediatrician. So if you're a teacher, you would then be sharing your concerns with the parent.
Yeah.
And then the parent's next step, and as a teacher, you could recommend this, is speak to your pediatrician, explain exactly what's going on.
Exactly.
And what age can this start? How young can a child be when these types of symptoms get in the way of their functioning?
So we can see the signs of anxiety even during preschool, before children even go to school. It's quite rare for anxiety to be impairing or for anxiety to interfere with a preschooler's ability to function. It really becomes much more common in the early school years, and we see a change in the flavor or the symptoms of anxiety. In the early school years, what we tend to see is worry about specific objects or specific situations, like being alone or being separated from parents. As kids become preteens and approach adolescence, we see that tends to shift and focus on social issues. So in the 9, 10 to 12 to 14 year, that's really where we see social anxiety as becoming most common. And then a few years later, that's where we see general worries about competence, how well you're going to do in school, how you're doing in sports, do other kids like me? That's where we see those symptoms. So really, it's all throughout childhood, once school begins, where we see it, and we see different flavors of children of different ages.
So tell us a little bit about what's the treatment. So you go to the pediatrician may suggest going to a psychiatrist, a psychologist, some other mental health professional. What are they going to do?
Yeah, so the usual thing that we want to do is two things. The first thing we want to do is help children to learn how to use constructive thoughts to control their anxiety. And there are a whole range of techniques that children can learn. Typically, that's with a therapist. And then the second thing we want to do is make a list of all the things that worry or concern children. And you want to work with a therapist who's going to help the child and their family do what we call exposure. That means facing your fears. You're going to want to start with something that's maybe slightly anxiety provoking, and you're going to want to have the child learn those new skills that they've developed to control their anxiety. And you're going to want them to succeed in a mildly fearful situation. And then as they learn how to do that, you want to gradually increase the exposures. And we call this form of therapy cognitive behavioral therapy or exposure therapy. And that's usually the first line treatment that most people recommend. Now, that's not an easy thing to do, partly because the therapist has to have some skill, and you have to have some experience in helping children learn how to do that. And for some children, it's simply too difficult. For those children, the other treatment that we consider are a certain group of medications, what are called selective serotonin reuptaker, or SSRI inhibitor medications. And there's some debate about whether or not we should consider those first-line treatments or not. I think a lot of people think that if an experienced therapist is available and a child is willing to engage in cognitive behavioral therapy, I think most people recommend starting with that. That said, there are not that many experienced therapists, and not all children will comply with that. So in that situation, it's perfectly reasonable for a child to be treated with one of these SSRI medications.
And so let's say they're taking the medicine. I want to talk a little bit about that because parents are often appropriately concerned about giving their child medicine, especially on an ongoing basis. What do you say to a parent about that?
Yeah, well, so we have really a lot of information about the safety of the medication in the short term, meaning that for 1 to 2 years, and all the information that we have suggests that the benefits far outweigh the risks. There are considerable risks to the child when they have serious anxiety for having that anxiety not treated. And the benefits of overcoming their anxiety in the short term clearly are greater than the risks of not treating the anxiety. Now, again, we could debate, does it make sense to start with cognitive therapy first? It probably does. But again, parents can really be reassured over 1 to 2 years. Where things get a little trickier is if you get over 1 to 2 years. And I think different physicians, therapists, and scientists feel differently. Anxiety has a very good prognosis. Most children can overcome their anxiety, and it might come and go, but most children can get to the point where their anxiety is substantially better. So I feel for children who have responded to a medicine and are doing well, after a year, I like there to be a trial off the medication. Not so much that we know there's something bad about taking the medication for a long time, but we have less overall information in terms of long-term treatment. Now, not everybody agrees with that. Other people think that, anxiety can be chronic, and, if you get a child well, some people recommend that the child remain on the medication for a number of years, and they point to the fact that there really is no evidence that the medicine is harmful for many years. I tend to be more cautious. Again, mostly speaking to these kinds of concerns that you were echoing, that I hear from many parents, and also with the fact that many children come off the medicine and they really do fine. Some don't do fine after they come off the medicine, and you can always just put the child back on the medicine for another year. And I feel more comfortable, and many of the parents that I talk to feel more comfortable in that situation. That said, this is why organizations like BBRF are so important. It's very important that we continue to do more research, particularly on the long-term safety of these medicines, so that we can be more definitive about how long we can safely keep a child on one of these medicines.
That's a good point about the importance of research, and you've dedicated your career to that. That we know a lot, and with what we currently know, we could help a lot of people, but we still need to learn more to do even the job.
One other really important thing to think about and to note is that there's a very strong relation between having anxiety in childhood and developing depression in adolescence and adulthood. And unlike anxiety, which we are quite effective in treating, we have a much harder time in treating major depressive disorder in adolescence or in adulthood. So a lot of people, and I'm one of them, think that not only is it appropriate to treat anxiety and use medicine when CBT is not available because you help children in the short term, you relieve their suffering and you help them to function better, but it also might be important because it might reduce the chance that they're going to develop a major depressive disorder years down the road, which will be harder to treat. And there the options are much fewer, and the duration of the remission once we achieve it is not as robust.
So it's a very important point you're making, that we in the field of psychiatry haven't in the past focused as much as we're moving towards focusing on prevention. In other fields, we do. So for cardiology, if somebody has high blood pressure, we treat that, or high cholesterol, we treat that to decrease the risk of a heart attack down the road. And you're saying that a benefit of treating the anxiety with talk therapy or medicine or both is not only helping the child in the here and now, it potentially decreases the risk and prevents them from developing something else, namely a depression down the road.
That's exactly right. And it's interesting you bring up the point about prevention. You're absolutely right. People are particularly nervous if we're going to try to prevent something in a child who's functioning well, who's not having any problems at all. And I do think it's reasonable to think about treatment in a child like that, because you are introducing the ideas of stigma. All treatment's not free, and all treatments have risk. The story is very different in anxiety, because it's not only that you're potentially preventing a problem, but children with anxiety suffer considerably in and of themselves. So, you're kind of getting a 2-for-1 benefit when you treat anxiety. You're helping the child in the short term. We know that's the case. We know that you're making a big difference in the immediate life of that child. And you might also, exactly as you said, be inoculating that child against later risk for depression.
You mentioned at the beginning that this is very common. 10%, 1 out of 10 kids have it
at any one time. That's at any one time. If we follow kids over time, it's probably at least double that.
So this is, lots of kids have it. So teachers are seeing it, parents are seeing it. Has the rate increased over time? Is it more common than it had been in the past?
That's a very tough question to answer, because a lot of things can change it. So, for example, again, through webinars like this and efforts from BBRF and other organizations, stigma has gone down. So people are more willing to talk about it. And that could, in some ways, artificially inflate the rates of anxiety disorders. And I think there was some concerns that some subtle upticks that we were seeing maybe 20 or 15 years ago might have been related to that. The data that we have now, though, suggests that there probably has been a genuine increase in anxiety. In the years immediately before the pandemic, but then clearly with the pandemic. It's pretty clear, even among relatively conservative scientists like me, that the problem is worse now than it was definitely 10, but probably even 5 years from ago. Now, I don't know that I would go as far as to call it an epidemic, because the rate hasn't been that profound in terms of the increase. But some people go so far to say that, and people like the Surgeon General or other important, prominent spokespeople for the health of the nation do talk about anxiety in that way. And I think that reflects pretty much agreement among everybody that the problem has gotten worse.
And obviously, COVID would be a clear-cut reason. Are there others, such as the use of social media and people, like what do people
Yeah.
see as potential causes for the problem becoming worse?
So we know a lot about what causes mental illnesses in general, and we know a lot about what causes anxiety. And pretty much all mental illnesses are not caused by any one or even any 10 or even any 50 things. They're caused by hundreds of things, all kind of interacting in complicated webs. And that's clearly the case with anxiety, number one. Number two, some problems like attention deficit disorder, ADHD, or schizophrenia or autism have a more prominent genetic component, even though they have an environmental component as well. And other problems like anxiety have a more prominent environmental component than genetic component. So we think things in the environment play into this increase in rate. So that's number two. Number three, the most potent thing that we see in the environment is stress. Children who are exposed to stress from anything that can increase rates of anxiety. Stress that involves social things is particularly harmful. So being bullied, stress in the family among parents. Sometimes we think when parents are struggling or when parents are dealing with their own mental health issues, we think that creates stress that contributes to anxiety. The hard economic times we think create stress. The issue of social media is a very interesting one. It's pretty clear that there is an association cross-sectionally, meaning that if we look at kids who are struggling the most, they tend to use social media the most. However, longitudinal research suggests that not much of that is probably causative. It's probably more that kids who are suffering seek out certain kinds of social media as opposed to that kids who use social media and don't have problems get worse. That's probably relatively rare. On the other hand, social media is becoming such a ubiquitous part of life for children that it has become a conduit for stress in the same way that all activities that children do have an opportunity for stress. So without question, the availability of social media has made it possible for children to be bullied in unique ways. And we know that bullying is a big factor and risk for anxiety and mood disorders. So I don't think it's social media per se, as much as all the things going on in society right now that are contributing to different kinds of stress.
So you bring up the point of bullying, which in this, in our day, if we were bullied, it would be in the schoolyard, and then you'd go home and you'd be safe and sound and away from it. Whereas
Yeah,
now you're bullied and it continues when you get home on social media.
absolutely.
So
Absolutely.
if a teacher is aware that bullying is taking place, that would be a reason to think that child who's been bullied
Yeah,
might be at a higher risk
absolutely.
of
Absolutely.
anxiety.
And I was glad you brought this up. Teachers are in a difficult position because, on the one hand, they're on the front lines. So they're seeing a lot of things. And we know this from working with teachers and studying children, that teachers see a lot of things that other people don't see on the one hand. On the other hand, teachers really need to involve the parents. And, I work a lot with schools, and not all parents necessarily think that mental health issues are the purview of the school. So how to handle that in a delicate way, where on the one hand, you really are entirely working through the parents. On the other hand, you're handling it when parents might not want to hear these problems by staying with the family. That can be a difficult situation. And it's a place where I think having mental health experts within the school, people who are part of the school, who understand mental health concerns, can be really helpful, particularly in those situations.
What in just in our time that we have, what does the teacher say? What's the best approach for a teacher to engage the family, not to make them frightened by this, but engaged in helping their child? What should the teacher say?
Yeah. So I think a place to start is to describe the behaviors that you're seeing, and to see if you can engage the parents' concerns, and see if you can get parents to the point where they can acknowledge that it's a problem and they want to get involved. So that's usually the best first thing to do. The second thing you want to do is you want to really titrate your discussions based on the comfort level of the parent. Some parents will immediately want to hear about what does a teacher think and what can be done. And that would be a wonderful opportunity for teachers to talk about this webinar that they attended. And usually the pediatrician is the first place to go. And it's particularly helpful when there's some understanding of who the pediatricians are. Not every parent can hear that. So in that situation, the ideal scenario is if there's some people within the school that parents are willing to speak with the teacher. Ideally, that would be the guidance counselor. Wonderful guidance counselors are able to have those conversations with teachers and parents. And that sometimes they have a little more experience with this. Guidance counselors are tremendously overtaxed as well, though. So in these situations, a teacher has to keep trying all different kinds of things, working with your principal, working with other resources to try to get a parent to at least have an open ear to hearing about the problem. And I think eventually where you want to get is to the pediatrician. That's really where you want to go.
And on the other side of the coin, for the parents who are watching, what guidance do you give them when the teacher is approaching them and they're not sure exactly what this means? What should they do? What should they be listening for from the teacher?
Yeah, two or three things. One big thing is think about impairment and ask the teacher about what are the signs of impairment and what are the behaviors that their child can't do, number one. Number two, you should figure out if this is a change. When a child has been having a problem for a while, it's more likely to be an indicator of a significant mental health issue. If it's a new problem, it's less likely to be a serious mental health problem. Number three, in that instance, typically when something's changed and a child is having a hard time, something has typically changed in their environment. And teachers often have a sense of this. Has the friendship dynamic changed? Is the material more difficult? Is there something else about the activities in which a child is engaging? And as a parent, you want to look for those signs and look for those clues, and you want to get to a place where you can discuss them with your child. And that can make a huge difference sometimes. Just a child knowing that somebody's paying attention and removing some of those immediate stressors, that can really significantly reduce anxiety.
I think the point that the child knows people are aware of it, care about them, and are intervening, I think that makes a very big difference for the child. They're not alone
Absolutely.
anymore. And often
Absolutely.
people don't, at all ages, don't want to talk about these things.
Absolutely.
Having that conversation is helpful in its own right.
Absolutely. And that's why I personally think, again, not all schools agree with this, but having conversations about mental health in the schools in many ways can be a good thing, because it shows that this is a common problem that many people face at different times in their life, and it's good to talk about it. It's helpful to talk about it. But not everybody feels that way, and we need to recognize that.
Well, I think we need to speak with people where they're at, but certainly we need to move towards a level of comfort about talking about these issues. And as we finish up today, first of all, I want to thank you for joining us this evening and afternoon on the West Coast, and also thank you for the work that you've done, which has had such an impact on the field. And I know that you've helped so many people on an individual basis and on a broad basis as well. So
I feel
thank you.
really fortunate, and it's a gift to be able to do it, and I'm eager to do more. So
Great.
thank you, Jeff, really.
Well, you're welcome, but the thanks go to you. I also want to thank everybody who joined us today. This is being recorded, so it will be available as a resource. So I encourage people to share this with colleagues, with friends, with other family members, so that people could join in and really hear the extraordinary wisdom that you share, Danny. So thank you so much.
Absolutely. Have a
Take
great
care.
evening.
You too. Bye bye,
Bye-bye.
everybody.